Good afternoon, ladies and gentlemen. My name is Rainer Buchhorn. I'm pediatric cardiologist, and I want to talk about the special importance of the heart rate for health and disease from heart failure to long COVID. There are different methods to measure the heart rate. These are the traditional Chinese way to analyze heart rate variability, but today we use the 24 Holter ECG or the monitors in the intensive care unit, or the half-hour scanner from BioSign for the active standing test, and everybody has the opportunity to measure his own heart rate and heart rate variability with fitness trackers. Indeed, there's very good register data from Sweden who show that the heart rate have an impact on cardiovascular risk. Most of all, the incidence of heart failure is increased in those young adults who have the highest heart rates. Most of the data from the big heart failure trials showed that the heart rate reduction prolong the life in patients with heart failure. And other drugs who increase the heart rate shorten the life. And the big heart failure trials show that the prescription of beta blockers is the cheapest way to prolong the life in patients with heart failure. I introduced beta blocker in pediatric heart failure therapy 27 years ago, but unfortunately there's a bitter struggle of pediatric cardiologists for their ineffective heart failure therapy with digoxin, diuretics, and captopril, as shown in this slide, and we have no progress in mortality in the pediatric population, in contrast to the fantastic furore with high significant improvement of prognosis in adult cardiology. But perhaps the pediatric heart failure therapy will improve in 2023 after these two publications who show that the elevated heart rate in the US registry have a significant impact on mortality, and the real-world data about the use of cardomyopathies in children with dilated cardiomyopathy from Italy show the impressive effect on mortality. But the effect of mortality in pediatric heart failure is more dramatic in those infants with congenital heart disease who have the highest mortality rates, as shown in this single center observation, with a very high mortality in the infant who have the highest mortality. The US cardiologist trial didn't include those infants with heart failure due to congenital heart disease. We have to show on our trials about propranolol in infants with heart failure, or the Indian VSD PHF trial, or the Gießen approach to the hypoplastic left heart syndrome that include 100% beta blockers. And we have to remember that the congenital heart disease and heart failure due to congenital heart disease remain the most important cause of mortality in infants, despite the success of modern congenital heart surgery. The data from Norway show the congenital heart defects who have the highest mortality, and now I demonstrate our own data from propranolol treatment within the last 27 years. I treat the most severe heart failure patients with propranolol in 37 cases, 16 have a Down syndrome, and of this group, 3 babies died, of course, an unbalanced AVSD with Down syndrome, and we have a nearly 100% survival after using propranolol in these congenital heart defects. Most of the atrioventricular septal defect, furthermore the pulmonary atresia, furthermore those patients with truncus arteriosus communis, furthermore with patients, infants with single ventricle, and those patients with ventricular septal defect. The Gießen experience show a 98% survival by using beta blockers in children with hypoplastic left heart syndrome. After the introduction of propranolol in pediatric heart failure therapy, I have a long time, for 27 years, to think about heart rate regulation and other disease like the postural orthostatic tachycardia syndrome and the inappropriate sinus tachycardia. I investigate about autoimmunity and ADHD and some other disease. And there are 4 regulators for heart rate regulation. The first of all, the autonomic balance treated with beta blockers. Furthermore, the funny channel treated with ivabradine, and the sodium channel with omega-3 fatty acids. We investigate the impact of obesity and anorexia nervosa on heart rate in other trials. And all this have an impact on prognosis. And in this time, I realized that there are many other causes of tachycardia beyond congenital heart disease in children. For example, those who have an attention deficit disorder or obesity. And indeed, in this slide, there is the ratio of body weight to body surface area to the NN interval, and this is the line between the mouse and the horse, and the healthy children with normal weight are on this line. The obese children with high body weight have higher heart rates, and the children with a low body mass index, most of all, of course, anorexia nervosa, have very low heart rates. Again, this is the normal weight children, the low weight children, and the obese children. But a more sophisticated view on heart rate show that beneath the autonomic balance there are ion channels who depends on caloric intake, ivabradine, sports, or omega-3 fatty acids that also have an impact on heart rate that is overviewed for a long time. Looking to this view, we have the impact of sympathicus and parasympathetic of the current heart rate, but the third dimension is the mean heart rate that is influenced by ion channels like the funny channel. These are our own data with the diagnosis of an inappropriate sinus tachycardia in a Holter ECG, and we need a second test, the active standing test, to recognize the adolescents with the postural orthostatic stress syndrome. We realize that we overlook the POTS in the 24 Holter ECG, and we need a second test, the active standing test, to make a proper diagnosis. There are also a guideline from 2015 about the diagnosis and treatment of postural orthostatic tachycardia syndrome, inappropriate sinus tachycardia, and vasovagal syncope. We see the definitions with an increase of heart rate from more than 30 beats per minute in the postural orthostatic tachycardia syndrome, or in adolescents more than 40 beats per minute from lying to standing. There's a definition of a sinus tachycardia of more than 90 beats per minute in the 24 Holter ECG. There are the many phases of the postural orthostatic stress syndrome. There are gastrointestinal problems, fatigue, weakness, dizziness, headaches, lack of concentration, all things that we see every day in our practice, and some may be related to the POTS. Currently, we realize that dysautonomia may be a cause of long COVID after COVID-19 disease and or vaccination. Our current data show that the patient with long COVID problem have a slightly higher diastolic pressure, normal myocardial function, but a significant increase of heart rate while standing that indicates postural orthostatic tachycardia as well as inappropriate sinus tachycardia. Again, these are the guidelines with the treatment recommendation. In the young, we have also the metadone treatment for POTS, but we can also use the pharmacotherapy recommended for adults. For the treatment of inappropriate sinus tachycardia, we have most of all the recommendation for ivabradine treatment. These are the adults' recommendation. The patient have to drink 2 to 3 liter water and may supplement sodium chloride. The pharmacotherapy may be done by fludrocortisone, pyridostigmine, low-dose propranolol, clonidine, alpha-methyl-dopa, or intravenous sodium infusion for the most severe cases. The evidence is relatively low, but most of all, propranolol, ivabradine, and metadone have a moderate evidence. That's the reason why we use the lifestyle advices and the nutritional supplements with omega-3 fatty acid. We will show the data and the next slides. We use low-dose beta blockers like propranolol. We used ivabradine, and we also used metadone for symptomatic treatment, but in the most severe cases, sodium infusion. This is a slide from our current recommendation, from our current paper about therapeutic approaches to dysautonomia in childhood with a special focus on long COVID. This is 13 years old. Adolescents with vagus collapse while standing. We have a very good heart rate variability and heart rate variability while lying in this athlete, and while standing the vagus completely collapsed, and we have nearly no heart rate variability due to this circumstances. The heart rate increased to 120 in this boy. These are our therapeutic effects on heart rate. The omega-3 fatty acids plus propranolol plus ivabradine, and there is a significant decrease of the heart rate increase for all 3 treatments. There's a significant reduction, most of all by reducing the standing heart rate. In the inappropriate sinus tachycardia, all 3 treatments have a significant reduction of heart rate in the lying and standing position. Fatty acid supplementation. These are the data from the PLOS-ONE publication, and there are a significant increase of the heart rate in the 24 Holter ECG with lower heart rates in the green line in children after 3 months omega-3 fatty acid supplementation. There are some recent reviews about inappropriate sinus tachycardia and postural orthostatic tachycardia syndrome, and in all these publications that the role of autoantibodies on dysautonomia, and indeed we measure autoantibodies in children with multisystemic inflammatory syndrome, long COVID, and those with problems after vaccination, and all these children have elevated autoantibodies autoantibody against adrenergic receptors and some vascular receptors. And maybe that the long COVID is an autoimmune disease, and this is important to know. Thank you for your attention.